I look at ruptures a little different now. And you're human, I'm human. We had a rupture, but we noticed it, we named it, we reattuned ourselves to it, and then we got better for it. It's almost see it as like scar tissue that's stronger than it was, beforehand. And so maybe the first time that person suffering with NPD was able to repair something, having a relationship, being able to have a rupture and be able to repair it, and then we're fine. We're stronger now.
The ruptures are inevitable. The repair is the part that makes therapy therapy. Okay, well, hi everyone. Welcome back to this, our second installment of the seminar series here on the Heal NPD channel. I'm joined by my psych associates here, Mr. Danté Spencer and Miss Deanna Young. And I'm wondering if just to refresh everybody's memory, you could just kind of reintroduce yourself just briefly and any pertinent facts about yourself that you feel like might be helpful for folks to know, and then we'll dive into the article that we're reading this week. Deanna, I think you went first last time, so we'll start with Dante.
Okay. Hey, so I'm Danté Spencer. I'm currently a doctoral student in my all but dissertation phase at Pacific Graduate Institute, where we emphasize not only clinical psychology, but depth psychology as well. And my current dissertation is on the exploration of emotion in a psychotherapeutic change for specifically ISTDP, which is intensive short-term dynamic psychotherapy, and its effects with treatment-resistant anxiety. And so, newly training and apprenticing under Dr. Ettensohn, and I'm happy to do so. I feel really connected to NPD and this disorder and the way that Dr. Ettensohn does not demonize, but rather tries to heal and help out people that are suffering from the disorder.
Go on. All right. Brownie points one. Now, thank you for thank you, Dante. And Deanna.
Hi, everybody. My name is Deanna Young. I recently completed my doctoral education in clinical psychology from LA International University. And I finished my internship at the Renfrew Center for Eating Disorders. I'm really interested in trauma, particularly interpersonal and systemic trauma, which really interests me about NPD, the interpersonal aspects of it. Similarly, really enjoy apprenticing under Dr. Ettensohn for the compassion he brings and just perspective. Not trying to get brownie points, just trying to connect. Happy to be here and excited to talk about the article.
All right. Well, I am thrilled to be working with both of you as well. Okay, great. So let's jump into the article that we're reading this week. I'm gonna, like I did last time, I'm gonna read just a brief synopsis here so that the folks who are watching have a sense of what the article's about, and then we'll get into it. So today we're discussing Principles of Psychodynamic Treatment for Patients with Narcissistic Personality Disorder by Holly Crisp and Glen Gabbard, published in 2020 in the Journal of Personality Disorders. Crisp and Gabbard present an integrative psychodynamic framework for understanding and treating narcissistic personality disorder. They describe NPD as pleomorphic, which means that it appears in many forms and different levels of severity, and they emphasize the need for a flexible, individualized therapeutic approach. Rather than applying a single model, they encourage clinicians to adjust interventions based on the patient's level of organization, affect tolerance, and reflective capacity. The article, the article outlines a spectrum of narcissistic functioning. It also revisits the distinction between grandiose and vulnerable narcissism and draws correlations roughly to Kernberg's conflict model and Kohut's deficit model, while emphasizing that most patients alternate or oscillate between both states. Glen Gabbard's paper in 1989, titled Two Subtypes of Narcissistic Personality Disorder, was among the first to articulate this duality between grandiosity and vulnerability. It was actually the first time that I encountered this concept during my dissertation research, and it profoundly shaped how I've come to understand narcissism as a dynamic, context-dependent process rather than some fixed type. This later collaboration with Holly Crisp extends that earlier work into a practical framework for treatment. The authors highlight shame as the central organizing affect in NPD, influencing both grandiose and vulnerable presentations. They also described predictable transference, countertransference patterns, the need to move flexibly between supportive and interpretive approaches, and the value of balancing empathy and structure. Ultimately, they advocate for a pluralistic and compassionate approach, one that helps patients develop reflective capacity, a more cohesive experience of self, and greater tolerance for ambivalence so that narcissism becomes more integrated and capable of sustaining authentic relationships. All right, so that's my synopsis. I guess the first thing, maybe we can just take the pulse of the group here, and I'd love to hear just broad impressions, what you guys found interesting, what you found helpful, things maybe you disagreed with or had questions about.
I really liked how the article talks about that fluidity, and not being fixed. As a therapist, you know, to not have like this manualized approach, um, um, which you'd think that you would need, but I guess it kind of helped me see things a little differently. There's an improvisational aspect of just kind of being there, and so much of that, the treatment is the therapeutic relationship.
Mhm.
Like the treatment is that the therapist's central instrument for the relational dynamic. So sometimes it's nice to hear that, because at times treating, I think we need to do something specific rather than just be, um, rather than just contain, rather to have empathy, judicial interpretation. That's one of the things that stood out for me. I
Mm.
think early on in my clinical training, at my first practicum, I remember my supervisor uh, said that I was a little quick to interpret on a specific uh, patient I was working with, and I didn't really understand at the time because it was just so laid out in front of me as a therapist to see what was happening, and I interpreted in that first session. And he said that in supervision, and then the client never returned.
Yeah.
And so it was a learning experience that I interpreted too quick here, and I didn't really understand at the time what that meant. But I really was able to be aware of what that can do, to someone that's struggling in this area. And so I guess we know that the central theme of this is shame. So I'm wondering, like, that interpretation too soon, or maybe just interpretation in general with a fragile patient, maybe almost exacerbating the shame in a way.
I think it's a great point, Dante, and um, I've had that same experience many times where I feel like I can see something so clearly, and I'm like, well, of course I would say it. Of course, wouldn't it be helpful if I just laid it bare, just on the table, exactly what I feel is going on here? And usually the person behaves at least receptively, but yeah, more often than not, they're gone. Never see them again. And I think you're right. I think it does speak in any therapy to the importance of pacing. And I think I like how you put sort of judicious use of interpretation. I think the authors also talk about that in the article about the importance of kind of a well-timed interpretation, and how interpretation has to be embedded in a kind of sound alliance, such that it can be received without shame, or that it can be received in a way that doesn't feel like just more criticism or just another
Mm.
performance demand. Um, and and I think we run the risk of activating painful but familiar false self dynamics when we kind of aren't careful about how we how we talk about things that feel deeply personal and challenging and like high stakes maybe to the patient. So yeah, it sounds like a really good lesson to learn early. I wish I had learned that lesson uh, earlier than last week. No, just kidding. Earlier than I did. I went for a little. I think I went for a while before that was clear to me. I was trying to be clever and useful, and I didn't quite understand what that meant in the context of psychotherapy. Um, yeah.
Yeah, what's interesting too on this continuum where there's an interpretation and say maybe on the other side would be like empathy, right? And then implicitly discussed like how empathy could also um, be almost shameful to
Mhm.
the patient. Because and I don't know how what you guys would think about this, but it almost seemed to me that in that case, if it was like too much empathy, where the patient could think that I don't know that something's wrong with me. I'm I'm not good. This person's feeling sorry for me. I'm flawed, and I wonder if that could also exacerbate shame if there was like too much empathy. So I don't know. That's one thing I would like to talk about, like how to gauge that phenomena or what it
Yeah.
would look like with too much, and how that is taken in by the patient.
Yeah, I think you're really hitting on an important calibration that is, I don't know if the authors specifically say it, but it's certainly implied throughout this article. When they talk about that kind of like supportive to interpretive continuum, and they talk about how each treatment needs to be tailored to not just the individual, but to the issue, like the stuff that's coming up right now for the person, because of the interplay between sort of grandiose and collapsed or vulnerable self states. There are times, I think, in the treatment of pathological narcissism and NPD where uh, an interpretation or an attempt to kind of get close, like an empathic reflection could feel really good. And there are other times where it could feel intolerably exposing
Mm,
and too close, you know? It's almost like I almost think about it like a form of touch, you know? And there are times when touch is not in therapy, but in life. I want to be very clear, we don't touch our patients. Yeah. There are times in life where it's touch is welcome. And there are other times when it's not. Um, and a lot of that depends on the quality of the relationship, but also the mood of the person and the context as well. So
mm,
um, yeah, we can get too close too fast and absolutely activate all kinds of stuff from shame to attachment avoidance as well,
mm.
right? Um, because it just doesn't feel safe to the person. Um, Deanna, I'm curious about your thoughts either about that or about another aspect of the article, whatever jumps out to you.
Yeah, kind of going off what you were saying, I really appreciate how the article emphasizes like focusing on the idiosyncrasies of each patient,
Mhm.
and kind of like we're talking about like how do you know like when to touch, when to pull back, how close to be, how not close to be. And I really like that the article emphasizes that you just need to know, or you need to connect with your patient and really get into their mind and really kind of understand and be there with them,
Mhm.
um, in order to kind of figure it out. And it's like a process of discovery more than knowing. And I like that position in the relationship. It feels so collaborative. And I think that's kind of what I guess how I really like to work, and how I feel a lot of like the manualized treatments kind of don't make a lot of space for, because there's such like there's such a power dynamic really, and that can really exacerbate distance.
I feel like there's a danger in a manualized approach, and just so everybody kind of knows, we're all on the same page. I know you guys know what that is, but people watching might not. So a manualized approach is like, where somebody says, okay, well, these are the steps for treatment for a specific issue. Usually it's a circumscribed disorder, major depressive disorder, or OCD, or generalized anxiety disorder, or, something like NPD. There are manualized approaches to treating NPD. And, I think that can be very helpful for creating a scaffolding for research. Because one of the big issues in research, especially for complex mental health disorders, is that it's hard to know, or if whether or not two clinicians are doing the same thing.
Hmm.
So, then you can't, it's difficult to discern then, okay, well, is the change because you just had a really talented clinician, or is it because of the intervention they were using, right? Um, so manualized treatments can be helpful there. But I think it's just so important for clinicians to recognize that this is a conceptual scaffolding and not a necessarily a prescriptive, mandate, right? It's not, wait, you went from step one to step three, like as you might imagine for like like a medical treatment. Um, Psychotherapy is a dialogue. It first and foremost always. And if you substitute form, the kind of like, well, first we have to talk about step one before we talk about step three, in an inflexible manner, especially with an issue like NPD, where the person's dealing with maybe a history of traumatic empathic failures, right? Um, and here they're trying to tell you something and have it be received in a way that feels like they're seen and understood. And you're like, I am the robot. Step one before step, then that can kind of to your point last time, Deanna, re-injure the patient and cause a rupture in the therapy. Um, and it can feel yeah, like the protocol is more important than the person. um so my impression from this article is that the authors are not fans of a rigid manualized approach. And what they're arguing for here is an adaptive approach, one that pulls maybe from different frames even, um, because of this idea of pleomorphism, which is this is the only time I've seen this word applied in psychology.
Hmm.
It's typically like a biology term, but I think it works well here, and I also kind of want to just talk about that. Um, you know, what does it mean to you guys, I guess? And I can talk about what it means to me as well, but that NPD is pleomorphic.
It's interesting. because so much of this, like I'm reading this, and it's discussing the therapist and the interaction with NPD, and we were just talking about like the fluidity versus, let's say, rigidity, and it seems that so much of this need for being flexible, the pleomorphism, but almost contradict the primary caregiver's um, caregiving to the person while growing up. And it almost seems that like the repair in this is that relationship, whereas maybe the parents were rigid and didn't behave in a fluid way. That that to almost unpack and undo that would be that the relationship would be the fluidity. Everyone's a little different, not treating all the kids the same,
Hmm.
right? Every kid's different with different personalities. So it kind of really started to see that that's how maybe it developed in the first place, not being fluid, not having empathy, really being really rigid and controlling. So I just kind of see it almost like the pleomorphism is a way to approach that may have been likened to how, you know, a good enough mother, you know, could behave.
I
Yeah,
really
yeah.
like that perspective. Yeah, I really like that the way you put that, Dante. And like it reminds me of like an equitable approach where you're like meeting everybody where they are and where they need to be and giving like not treating all the kids the same. And I think that pleomorphic perspective is like it kind of captures the like an essence of being human because we're all so
Yeah.
different. And so it speaks to like such a depth of humanity like that we all have and that we all connect to, but that some of us were just like robbed from.
Hmm. Yeah, yeah. No, I like that too. I like that idea that there's a corrective experience. I think we're talking about a corrective experience. Um, one that's sort of it welcomes the diversity, the internal diversity of the patient, right? All the different parts, all the different feelings, without trying to superimpose some kind of form, or mandate or series of expectations um, onto the person. And I like this idea also, and I think right now I think you're talking about Kohut's model,
Yeah.
um, Dante, where it's this idea that these problems are well, if you ask Kohut, caused by. If you ask me, I think is a complicated interaction between temperament and environment, but so I would say exacerbated by for sure. Um, lapses in empathic attunement, right? Between the caregiver or caregivers, what I just call environment, basically,
Mm.
um, and the child. So the child needs something, doesn't line up with what the environment is prepared to respond to. And so the response is suboptimal. It's not good enough. It doesn't meet the child where they are. It doesn't give them what they need. Maybe it even punishes them for needing something that the environment doesn't facilitate, right? And this results in injury, um, trauma, right? Trauma is injury. It doesn't have to be like life-threatening trauma. It can just be injury. But you pile up enough injuries over a long enough period of time, and you're going to end up with disability, essentially. And this is Kohut's argument. That is the essence of his model. And that the disabilities that affect people with NPD have to do with self-esteem, regulation, and self-image. The quality of self-experience, the stability of self-experience, the resiliency of it, and the realism of it. Um, And so, yeah, I hear you saying like to be responsive to the patient is an intervention in and of itself, regardless of what you're talking about, regardless of whether it lines up with some manualized treatment or not, right? To just be present and responsive is good medicine for this disorder in particular, but I think for people in general. Um, I think, and this kind of also gets back to what we were talking about last time with the previous article. And Deanna, you made this really great point that there's a cultural I don't know construct around these issues that can sort of itself be an injury to this population. And the authors are talking about it here a little bit too. I feel like I'm taking forever to get to my points today. Uh, but like people are like, oh, narcissists, we know what they're like, you know, as though they just come in one form and it's just one prepackaged, like monolithic thing that everybody can recognize when they see, and that's it, you know. And these authors like are saying, no, there is no standard narcissist. There is no monolithic NPD. It is different for every person, and it's also different for the same person across sessions. So one day your patient is feeling grandiose, let's say, and the next they're in collapse. Um, and all points in between, you know. And that this is, I think, an idea that's sort of been missing from how we conceptualize these issues culturally, but also as clinicians, right? My mind goes back to that case conference I was in one time where my colleague was describing a narcissistic patient, and I kept saying, it sounds like your patient is narcissistic. It sounds like your patient's narcissistic. And then, like, after the third or fourth time, they were like, yes, I know, but how does that help me? And I was like, wait, you think I'm calling your patient a name? I'm not.
Mhm.
I'm telling your patient is struggling with pathological narcissism. Like that means something like psychologically about the person. It's not just like a name that we call people, right? But so I think clinicians as well really struggle with these concepts. Just and not that they're hard concepts, but they're just not widely
Mhm.
like talked about. Um, the next piece that I kind of wanted to get into here a little bit is the idea of shame as an organizing affect. That NPD is organized around shame. Um, they call it the axis around which grandiosity and vulnerability revolve. Um, I, I guess I
Yeah.
just
So with, yeah. So
yeah
with that, that was like kind of like the big underscored word for me in the article was shame. And so, is it that the person say that suffers from NPD, is it that they're just by all means trying to prevent feeling shame?
mm,
Because we know, I mean, we want to differentiate between shame and guilt, right? Shame is like this, almost like a public thing.
yeah
Guilt's more of an internal by yourself. Shame is like wide. So it's like, is it is it really trying to prevent the feelings of shame as if that would create the collapse, or um, maybe shame cannot be tolerated because of the fragile
mm,
self? Like, what is it with shame? Is it just the protecting of feeling that? Is the shame more? Is it, does it have a higher valence in someone with NPD than say, another person? don't know.
It's a good questions. Yeah. Yeah. Um, I've got thoughts about it, but I'm also curious, Deanna, if you had any thoughts about this. If not, that's okay too. I don't want to put you on the spot.
Oh,
Yeah.
oh no, it's okay. No, I'm curious to hear what you have to say to Dante's point.
Well, so the authors talk about shame as as a signal for kind of impending like fragmentation, I guess. Um, that's one way to think about it. So, that the idea that shame is sort of this to use like a public transit metaphor, like the electric third rail, you know? And like if you like I don't know if they have this in SoCal, Dante, but up here we have this public transit called BART.
Okay,
It's like
I
a
know Bart.
metro. Yeah, it's like yeah.
Yes.
And it runs on electricity and it gets its electricity from the farthest rail that's out from the platform. So there's an electrified rail basically.
Okay.
Um, and all of these signs that say don't touch the third rail essentially. Like it's
Mm,
you'll die. It's electric, right? So
mm,
this is like I think shame is like the electric third rail
mm,
for these particular issues. Um, but I also think about shame as like a traumatic affect. Um, so an area of self-experience that is so embedded with trauma that to feel
mm,
it is destabilizing and disorganizing and fragmenting. It's like, okay, I can hold this together for the most part, most of the time, let's say, but I get zapped by that third rail and it all falls apart, basically.
mm,
And that happens enough times, and then you start to develop all of these kind of sequelae, all of these um, associated syndromes, right? Now I'm anxious about getting shame activated and falling apart, right? Now I'm avoidant of certain interpersonal experiences because it activates anxiety about feeling shame. Now I'm reactive to, minor social cues that suggest to me that a shameful encounter is coming, right? Now uh, I can be enraged. I have a hair trigger, right? And I'll rage at somebody if it seems like they're trying to make me feel shame. So
mm,
all of these issues, like this bouquet of problems, develops around the issue of shame. And this is sort of the way of complex trauma, right?
mm.
Mhm. Mhm.
So could we argue, uh, to generalize, that somebody with NPD would have more trauma around shame, or experiences around shame and traumatic experiences around shame than maybe a person that didn't suffer from that?
That would be my assumption. Yeah. I think I see this a lot. And not just from like folks who watch the channel in their comments, but also from other content creators, right? Like I'm preparing to have an online discourse with this author, um, and so I was reading his book, and he makes this argument that, look, lots of people are traumatized and they don't grow up to have NPD, you know? So how can we say that NPD is caused by trauma? If all these people are traumatized, but they're not narcissists, And it's like, okay, but that makes the assumption that all trauma is the same.
Mm,
And if we remember that trauma is injury, right? You and I can be injured in very similar ways and have totally different outcomes. right? If you use the physical comparison, right? Have you ever been in a car crash? Have you?
Yep.
Yeah. Have you, Deanna, ever been in a car crash?
Minor.
Minor? Okay, yeah. I've been in a car crash as well. I mean, I'm assuming minor because we're all like sitting here and but um that must mean that we all had the same outcome, right? We were all in a
Mm.
car crash, you know.
Mm.
But no, so many factors are important here. From what angle was your car hit? How fast were you going? How fast was the opposing vehicle going?
Mm.
What kind of safety features were in the car, right? Was it an old car? Was it a newer car? Did it have airbags? Were you buckled up? All kinds of stuff matters. What position was your body in? Did you hit anything inside the car? Like it's so obvious when we're talking about physical trauma that I could hit two people in exactly the same spot and they would have vastly different responses. But for some reason, when we're talking about mental or emotional injury, it's like people just feel like it all's just the same thing, just trauma is trauma. And they're perplexed that similar, though not the same, traumas could produce wildly divergent outcomes in people.
Yeah, and I think that's a really good analogy that you're making with the car accident. Because if you think about like an injury, right? If we got into an accident, well, it's also the repair, right? So
Mhm.
if there was a support system in place, say if there was some sort of injury, but there's family, there's friends, there's people they connect with, there's people that help them get through it, versus let's just say a single mom, and that's all the kid had, and there was a huge,
Oh God, yeah.
trauma or rupture to that. There's really nothing. There's no, teachers, uncles, family. There's a lot of
Yeah.
things, but the healing. So we got injured, even if it was the same injury, it's like, well, did you have sutures? Did you clean out the wound? Did you nurture it, or did you just like throw dirt in it and expect it to heal,
Yeah. Yeah.
appropriately?
I was about 6 years old and I was in the back seat of the car and this was before nobody had booster seats or whatever, so I mean, there's this little kid in the back seat of a car just with like the lap belt on. It didn't even have like a shoulder harness, right? And there was this metal, what do you call it? Like a hand cart, like the kind you use to move heavy boxes and stuff, in the seat next to me. And it was just in the car because we'd been using it, or I don't know, my stepdad at the time had been using it to move something. He was in the front seat. We go through this intersection and the car is T-boned luckily on the side that I wasn't on, right? This car runs the red, hits us just right, T-bones, and I flew over and whacked my head on that metal hand cart, right? Lost consciousness, woke up with the paramedics there.
Oh,
Um, Now that's like it's just by the grace of whatever you believe in that that it wasn't a TBI that was life altering, right? It just good fortune that that didn't happen, but it could very well have happened, you know. My life could have been in alter like totally indelibly altered by that. And I just so happened that it wasn't. Maybe it was that I didn't hit it at the right angle, or my head wasn't going fast enough, or whatever, I mean, so head injuries they're not all the same, right? And neither are relational traumas.
good point.
Um, some you have the injury and because of the social support, because of the medical support, because of just good fortune, they're okay. And other people are not. Um, so I think when we're talking about NPD in particular, Yes, there's trauma around shame and all kinds of usually inflexible or maladaptive defenses that develop to try to protect the person from being re-exposed to that trauma, to the pain, basically. If trauma is injury, then being exposed to it is pain. But emotional pain, unbearable self states, essentially. Intolerable, you know, um, thoughts or feelings or experiences in your body, um, you know, in your feelings, in your self-image, in your images of other people, made all the worse because they're sustained in early childhood before your identity has formed and consolidated. Um, yeah. And I think the authors really they just really try to drill down into that reality with this disorder and um, and the implications that it has for the treating clinician as well. Yeah.
That's what I liked that they talked about was like how the clinician might feel within themselves and what it brings up within them.
Yeah.
Um, and I think I really liked that back to like just how much humanity is like represented in this disorder and in
Mm.
this struggle of like because I feel like you know oh well everyone goes through trauma so no big deal. That's like collapsing the complexity of what it means to be human and what it means to like be unique and be a self really.
Yeah.
And I feel like I just really like the way the article points to like understanding people through your own experience and your own self, to really get to those like early developmental wounds that like don't have language,
Mm.
and how confusing, right, for folks to want so desperately to connect but not know how, or to be so afraid of it. And yeah, I don't, that's just what I'm thinking about.
Yeah. Yeah, absolutely. And that ambivalence, right?
Mm-hmm.
And all of the maybe maladaptive ways of defending or protecting or coping that develop around it, right? Remember last time we were looking for this definition for I was looking for this definition of pathological narcissism and I couldn't find it. It's because it's not in that article, by the way. It's in a different article that the same author wrote. And
Uh,
I was like, why can't I? It's a different article. But anyway,
Yeah.
I went back and I found it. I don't have it here, but what they're saying is it is a combination of like instabilities in self-image and self-esteem combined with maladaptive coping, right? That's their definition for pathological narcissism. So it takes both of those things, the problems in coping combined with the internal instability. And the authors are talking about how those maladaptive relational strategies show up in the therapy, right? They've got a list of like 7 or 8 common transference, countertransference patterns. Um, I'm just going to read them off real quick, and then I want to get your impressions. The first one is treating the therapist like a sounding board. So just, like eh, using the therapist as like a source of positive feedback, basically. Um, Pulling for an empathic, admiring response. So like, aren't I good? Aren't I good? Right? Aren't I impressive? Like you guys were giving me at the beginning, right? Because I've trained you so well to, flatter me at the beginning of all of our
you're
public
so amazing,
conversations.
Mark.
I know
You're
it's
so
this.
amazing.
Yes. Thank you. Thank you for demonstrating. Um, Idealization and mutual admiration. So like the patient idealizes the therapist and the therapist is pulled into mutually admiring the patient. Um, Identification with vulnerability. That's where the therapist um, sees the vulnerability in the patient, and it resonates with unresolved stuff inside the therapist, and the therapist then tries to sort of rescue the patient, right? Envy and competitiveness. So the patient envies the therapist's goodness or intelligence or whatever that the patient perceives that the therapist has that the patient feels they don't. Um, Contempt and devaluation. So that's where the patient is contemptuous and devaluing of the therapist, usually as a defense against the patient's own shame, right? I don't need you, you know. Like, look at you over there, like, oh, you're so helpful, you know, like, right? This way of like trying to make the therapist feel worthless. That and what the patient's really doing is trying to evacuate their own shame. It's not in me, it's in you, right? Which is a common borderline level defense. Omnipotent control. That's where the patient tries to control what the therapist is doing. I think, you know, Deanna, you had a patient a while back that you and I were talking about that this dynamic was at play, right? Where the patient was um, trying to sort of control uh, the things that you said and did that, you know, because they had an idea in mind about how the therapy needed to go.
Mhm.
Um, and the final one is doer and done to. So that's where the intersubjectivity of the therapy relationship, right? That I'm constructing the patient and the patient is constructing me, and we together are constructing this intersubjective third, right? Us as a duality, basically. When that complexity collapses into this two-dimensional, you did something to me and I'm the victim of it, basically, which is a very common thread in our cultural discourse currently, especially around NPD. You know, you're the bad one, I'm the victim. No, you're the bad one and I'm the victim. No, you know, right. And it's like, and complexity, there's no space for that in that collapsed doer and done to dynamic. Okay. Those are the, there's quite a few of them, but those are the common countertransference, transference dynamics that the authors talk about. Do any of those jump out at you guys or seem particularly salient, or maybe you've experienced, you know, something like that in your own work or your own therapy, for instance? I don't know, you know. Yeah.
The doer and done to jumped out
Yeah.
to me, particularly the end of what they said, where kind of okay, what do you do with that? And what it really is both parties need to be known and seen.
Mm-hmm.
And that I just really connected with that. Just in like I guess the uniqueness of this treatment. And like really showing up and being in the room with your patient and like connecting on a human level and being seen. And I feel like that's important in like just modeling being seen, because it can be scary to be seen like as a human when you're a therapist.
Yes. I think I shared with you, Deanna, that time that I was still I was a fledgling, you know, therapist, and I was terrified that my patient had seen me walking to my car, and I because it felt so outside the frame, you know. And like
Mm-hmm.
I was exposed. I didn't have like my trappings, you know, like my protective carapace of like, you know, I am the therapist now, right? My supervisor was like, dude, like the therapy has to be like authentic for it to be anything. Like it's like dead on arrival if you're just playing this role, you know.
Mm.
Um, so yeah, you know, but you're right. It is scary to be known or seen for your in light of your like shit, let's say, you know,
Mm-hmm.
by your patient. So, you know, disrupts like the safety. of the power differential. Um, but that's precisely, I think, especially for patients who are organized in the more borderline range. Um, that is precisely what is needed and what they're pulling for, because they have to find out whether or not you're real, right? Or if you're
Mhm.
just full of shit, basically, you know? How far can I push you? How much can I poke at you before I get something that's real? Um, Winnicott writes about this in a fantastic article called "Hate and the Countertransference," um, and connects it back to early relational traumas that involve self experience. So, yeah. Um, how about you, Dante? Any of these jump out at you?
Well, speaking of this reminds me of the article talking about with ruptures, right? Inevitably, they're going to happen and they're important. And I feel that sometimes as a fledgling therapist, tries to prevent any kind of ruptures happening within the therapeutic diet.
Mhm.
And this article helped me see how important they are to, they're inevitable, but how important they are to repair that. And then what that's actually doing, what that's setting up. It's like, you're human, I'm human. We had a rupture, but we noticed it, we named it, we reattuned ourselves to it, and then we got better for it. It's almost see it as like scar tissue that's stronger than it was, beforehand. And so, yeah, I look at ruptures a little different um, now, and also the type of repair from ruptures in the therapeutic diet is maybe the first time that person suffering with NPD was able to repair something, having a relationship, being able to have a rupture, be able to repair it, and then we're fine. We're stronger now.
To
So
actually
that
have
really
a
stood out.
repair. Yeah, yeah.
Yeah.
And not have to have it be, some you know, part of some ongoing game of hot potato, with shame and deficiency, or some kind of zero sum game where only there can be only one survivor, or, only somebody's got to be bad, right?
Mhm.
I mean,
Yeah.
these are the things that I think good caregivers and parents do with their kids, where they're like, oops, I made a mistake. I'm sorry, mommy's just a person or dad's just a person, like, or oops, you made a mistake, and maybe I got mad and I'm sorry I got mad. I'm sorry I yelled
Mhm.
when you broke the thing. It was just really important to me. And, I felt sad and I felt so frustrated when you broke it, but people are more important than things. I mean, some kind of process where it's like there's a mutual acknowledgement or recognition. Both people are seen and known, right? To use what Deanna was saying. Um, and there's a recognition of the rupture. This is what happened. This is why. And then there's a repair. And I feel like the repair is the part that makes therapy therapy. The ruptures are inevitable. They're absolutely going to happen, right? All the time, over and over and over again. Sometimes you have to have the same rupture like a dozen times before there can be a mutual capacity for repair. But as long as that happens, that's where the change is, right? The corrective experience that you were talking about earlier,
Mhm.
Dante. Um, and that corrective experience is relational, right? And it becomes it's internalized then. Oh, there's this new possibility. There's this new experience. I don't have to hate you because you did something that made me mad. I don't have, it doesn't have to be that one of us ceases to exist as a good object forever and all time, you know? That's where that ability to sort of hold the good and the bad, to integrate those together is born. right? That is the, I feel like I'm like a mad professor with crazy hair right now, but like that's where that is the essence of this kind of therapy. The experience of relational rupture and relational repair. And you're absolutely right, Danté. Over time, it creates a stronger bond and more resiliency in the person, in the patient, such that they don't have to set up these scenarios anymore. Not that they were doing it intentionally necessarily, but they were compelled to do it because of the trauma that surrounds shame, right? And because of the internal instability and all of the maladaptive coping and protection that's developed around those issues. Um, to be able to feel like one was seen and held and known in light of the shame, in light of the trauma, in light of the whatever, and that it can still be okay and that we can still care about each other. That's that's the whole game, you know?
Yeah, and I'm wondering with that, Mark, how that can be modeled for, the self intrapsychically or intrapersonally, where when we have those conflicts, with ourselves, how we can repair that, how we could be okay with it and accept that, and
Yeah.
not split, not black and white thinking, but have a better understanding. So like almost improve, almost like through the repair and through repairing relationships with others, we can easily repair the relationship with ourselves when ruptures occur intracyclically.
Yeah, I feel like that's a process that needs to be introjected, needs to be internalized, because it's a process that we first experience relationally. Um, I did an assessment recently with someone, and I feel like I see this somewhat frequently, in the assessments that I do, where there's a diagnosis of NPD, which there was, but there was also this intellectual capacity, this ability to kind of like uh, intellectually make meaning out of the dysregulated, kind of shame-filled um, experience. It's sort of like there's like all of this like chaos, but then there's like this like form that's like imposed on it, and the form is intellectual, right? And it's stabilizing. It helps to keep the person together, essentially. They're holding themselves together with sheer like strength of like intellect. But that isn't enough for them to really feel like they can be um, integrated
Mm,
and whole, right? In other words, they're still struggling with the affective piece of it, the feelings piece of it, some of it maybe even pre-verbal, like you were saying, Deanna, right? That's the piece that has to be repaired relationally first, to my mind. And then it is through that experience that we develop the internal tool set to do it with ourselves.
okay. Yeah.
Which is why, people are always like, oh, give us a self-help book. Like, how do we do it? And it's like, I think you need therapy, like, or something like it, you know? Um, it's not that you can't get close, but I think it is like you need another person. Because these issues are so relationally bound, they're caused by relational trauma and they need to be relationally healed. Um,
Mm, mm. That's such a good point.
you know. All right, guys. we're we're at our time here. So
Right.
thanks everybody for joining us this week. We'll be back in 2 weeks with another article and another discussion. For those of you who are hanging in, we really appreciate it, and hope you find this stuff helpful. And thanks, Dante and Deanna, for being here as well.